YouTube streamer recording. You are behind the curtain with Dr. Schilling and Dr. Nordberg and I before we get started. So bear with us as we get things ready to go in about 30 seconds.
You who are watching.
And that's why I always start first, because there's a delay. All right, folks. I'm going to pull up the curtain in 3 seconds. 2 and action. Greetings, everyone, and welcome. This is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We've got a great topic that we're ready to cover today. I'm really excited to bring it to you. Those of you who are new to the show, we bring leaders together to not only inform our audience, but also, most importantly, unearth bright spots, wins, successes at health plans, provider groups, hospital systems around the country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas and successes shared on our show can be applied at your organization. We believe this approach of finding a bright spot and then cloning it is the most effective way to improve healthcare in our lifetime. If you've yet to subscribe to the podcast, Bright Spots in Healthcare, please give it a search in your favorite podcast app and subscribe. If you have subscribed but haven't yet given us a 5-star rating or made a nice comment, we ask you the favor of taking a couple minutes of doing that. That does matter in how we show up in searches on the podcast apps across the podcast ecosystem. So we thank you in advance for that support. Last week on the show, we talked about identifying and engaging silent sufferers and successes in doing that. Today, we're going to stay on the topic of mental health and whole person care, but we're going to talk about it more strategically and how organizations can reimagine how they deliver care from a people perspective, from a process perspective, and literally from a physical infrastructure, facility perspective. Imagine if mental health and primary care were one of the same. Reliant Medical Group is doing just that. So I want to just provide you some background if you're not local to the market. Reliant Medical Group is located here in central Massachusetts. I say here because I live in Metro West area of Massachusetts. Reliant has over 500 providers and cares for just about 350,000 patients. They offer a full range of primary care services and 30 different specialties with 19 locations throughout Central Mass and Metro West. So today we're privileged to have for the first time on our show, Dr. Tad Schilling, the Chief Medical Officer at Reliant Medical Group, and everyone's favorite regular guest on our show, Dr. Sam Nordberg, who's the Chief Behavioral Officer at Reliant Medical Group and has been with me on this show a number of times, and we love when he blesses us with his presence. He's awesome. So a perfect dynamic duo to help all of you learn about Reliant's thinking and their execution steps behind what I believe is to be one of the most innovative approaches to primary care in our country. Now, the NIH, they define collaborative care models as a pragmatic strategy to deliver integrated mental health and medical care for persons with mental health conditions served in a primary care setting. That's how they define it. Reliant really doesn't believe specifically in collaborative care. And I talked a little bit about this in some of my promotions to get you guys to all listen into today's episode. So I'm going to bring in Sam to talk about why they don't believe necessarily in collaborative care and how they define what they call full spectrum care and how that's being applied at Reliant. So go ahead, Sam, take it away.
Sure, and thank you, Eric. It's a pleasure as always to participate. Looking forward to questions toward the end.
Oh yeah. By the way, sorry. Thank you for that. Good segue. See, we're already working well together. Q&A module, folks, on the bottom of your Zoom interface. We will definitely have times to take them today. We've planned out. Usually, I don't have a lot of time for Q&A from the audience. We do today. Throw them in there. I'll integrate them into our conversation and save some for the end as well. Go ahead, Sam. Sorry about that.
So it's certainly not that the collaborative care model isn't a necessary and important part of behavioral and health integration, but basically we've taken the approach that it's necessary but not sufficient to address the needs of an organization like Reliant and our patients. And so, addressing and identifying and working on behavioral health concerns within primary care in the collaborative care model is sort of centered around the interaction between the primary care provider and supporting behavioral health, consultants, social workers who are working with the PCP to formulate a care plan for the patient and deliver on that care plan by connecting the patient with resources in the community and sort of facilitating the actual treatment for the patient. When we did this work to sort of examine our model, and Thad's going to go through sort of what strategically drove taking a look at our model and deciding how to change it. One of the things we identified was that there was no way the community was going to satisfy our need for treatment. And this then was the genesis of thinking about full spectrum care, was that absolutely we wanted to have the essence of the collaborative care model in that we wanted to be screening in primary care. We wanted to have people who were embedded in primary care with behavioral health expertise, working alongside our PCPs to help them to identify, rapidly triage, and work through what behavioral health concerns could be managed in primary care. And then we wanted to cover those critical areas of treatment that allowed us to own in-house the referral management and the quality control of prescribing, of psychotherapy, and to begin identifying particular patient populations or segments where we might want to, instead of looking to the community for expertise in treating those patients, we might want to build that expertise in-house. And so, for example, we have a substance use disorders treatment team that specializes in medication-assisted treatments. We have a dialectical behavior therapy center that is designed to deliver DBT, the gold standard treatment for borderline personality disorder, to patients. And those things exist for two reasons. One, because we couldn't find them in the community, at least couldn't find them in the community with the quality and consistency that we needed. And two, the value proposition was there. So an important thing to understand about Reliant from the get-go is that 55% of our patients are in some kind of value-based contract, meaning that, less than half of our patients are in fee-for-service. And that shifts our incentives and our approach to managing patients. And it means that, when we know that we're going to be working with a patient for many years, it makes a lot of sense for us to own the soup to nuts treatment so that we can invest heavily in getting that patient well. So that's the critical sort of component that we've got to work through when it comes to managing sort of complex and straightforward behavioral health in the full spectrum of care. And excuse me for a COVID moment with my 6-year-old. Hang on.
Eric, you're on mute.
I do these all the time, and I still catch myself on mute. I'm not the brightest bulb. So Tad, clearly a unique approach to primary care. Love the cameo, by the way, Sam. At a high level, Tad, what components make up your strategic approach? And then I got a couple of questions coming from the audience I'm going to jump in with after that.
Sure. So first of all, Eric, thanks for inviting me. I hope to become one of the regular guests and esteemed as Sam is on the show. This is really a great opportunity to showcase a little bit of the work we're doing and to hear from others across the country. So thank you for the invite. So really, let me focus just on three kind of big categories here of the strategic direction and philosophy. So the first is on care philosophy, right? Which is that, there's absolutely no reason why we should be segmenting or segregating physical health and mental and behavioral health. It's just a product of a very bastardized system of payment model through insurance with carve-outs, right? So I think every one of us who's a clinician knows that the interplay is real. It's pervasive in pretty much every instance. And so we believe very strongly in whole person care. We also believe philosophically that, teams are better than individuals in taking care of patients, right? Sam has expertise based on his training in clinical psychology that I don't have as a physician. And I have expertise that Sam doesn't have. And so together, we know we need to bring that expertise, that level of sophistication in actually managing patients together. So we believe in whole person care, and we believe in teams of providers using their individual skill sets together collaboratively to provide better patient outcomes. As Sam already alluded to, part of the reason that we can think differently about how we structure our primary care and behavioral health delivery model is because we actually aren't subject to the same degree of bastardization of the payment model. We have, as Sam mentioned, 55% of our patients in some value-based contracting, and it wouldn't come as any surprise to any of you on the call that if you look at the overall cost of care for patients, a lot of it comes out as medical costs, hospitalizations, emergency department utilization, worsening chronic conditions that ultimately have behavioral health underpinnings, right? And if we don't address the underlying driver of those medical problems from a behavioral perspective, the total cost of care is, and this is shown widely in the literature, 2 to 3 times, right? You take a coronary artery disease patient who has depression compared to one who doesn't, and the total spend on coronary artery disease care is 2 to 3 times higher. So what we do as a value-based care organization that takes risk is we say, we should put together the right services to take care of that patient so that we can lower the total medical expense. And it doesn't mean more people like me and more cardiologists necessarily for that patient. It means addressing the behavioral and mental health needs. So that's really the value-based care model that allows us to do that. And then you alluded already, Eric, to some of the opportunities that we've had from a kind of structural or operational perspective to truly deliver, I think, in a unique way, a care experience of integration. And so we actually built our current facilities around the notion that we need to be in shared spaces so that we can collaborate and communicate about the mutual management of patients with these kind of problems. So we actually embed behavioral health and primary care in the same space. About 2 years ago, I made the move as the chief medical officer to actually change our organizational structure to reflect our care philosophy. Historically, behavioral health was considered a specialty. It lived in our specialties division. I said, wait a minute, the greatest drivers of total cost and disability are actually being seen in primary care, where at least 50% or more of all presenting problems have a behavioral or mental health component. And so we actually moved behavioral health into primary care. So Sam reports through to a primary care chief, not through to a specialties chief. And that structural shift, I think, both represents the philosophy, but it also allows the collaboration to occur in a very real way. So those are really our 3 kind of key strategic directions in how we're developing this shared model of care.
Okay, actually, before I get to the questions, Sam, I'm going to do a follow-up. And by the way, folks, when I'm looking away from the camera, I've got my Q&A module to the right on another screen. So just want everyone to know I am paying attention. I'm just trying to manage everything at once. I want to summarize for the group here what you just said. So as it relates to full spectrum care, Tad, you said 3 big things. One was the overall care philosophy, which is centered around team-based care. The second was sort of the economic engine tied around value-based care. And third was an operational structure focused on shared spaces. So if I summarize, I got those 3 big?
You got it. Yep, shared spaces and true integration.
So I'll lob this out to either of you. What about the key roles in the model? Like how did the partner, the provider, the prescriber, like how does everyone, what are their roles, who's who, so folks could really understand sort of what it looks like?
Let me lay that out really quickly. So the partner is probably the closest thing to the sort of behavioral health consultant that's part of the collaborative care model. The behavioral health partners for us are all licensed master's level clinicians, and they spend their time integrated into the primary care space, and their jobs are principally to be ready for real-time needs as they emerge from primary care during the routine day of practice, and then to be available for structured triage assessments to get a full 360 picture of what's going on for every patient, and then to be the quarterback for that patient's care. So whether the patient is then getting connected with our tiered levels of service within Reliant, whether we're bringing in services from outside of Reliant, whether we're referring them to, to apps or other things that we have as part of our model of care, the partner is the quarterback. They're the ones who are making those decisions on the fly. And our partners are doing anywhere from sort of 10 to 35 triage assessments a week. And then available for real-time intervention, warm handoffs, and support with PCPs. Because of this, our partners have extremely low encounter expectations. I want to be very clear about that. There is a very, very low fee-for-service billable appointment expectation on our partners. The investment here is in getting that real-time conduit to connect primary care with our other levels of service seamlessly and fluidly. All right, so the behavioral health partner really I call the linchpin of the model. Right, and so then layered in there we have prescribing consultants. Right, so we have psychiatrists and psychiatric nurse practitioners who offer principally a consultative service. Right, so either through e-consults in our electronic health record or through some kind of collaboration facilitated by the partner, they're first determining whether they can simply offer the PCP some constructive guidance about how they could prescribe, that then empowers the PCPs to take care of their own panel without impaneling those patients with our prescribing consultants. Right? Then they may temporarily impanel a patient who's more complex, needs medication titration, some medication trials, and they may do that for 8 to 10 weeks and then pass the patient back to the primary care provider when that work is done. And that's a critical difference. We don't impanel patients. And Reliant patients, basically what we're trying to build for them is a sense that Reliant as an organization, primary care as a team, has their backs for whatever it is they need, which means they don't need to see a therapist every week or every 2 weeks in order to have access to a therapist. They don't need to be on a prescriber's panel in order to get expert prescribing. So then layered in there additionally are our behavioral health providers, right? So these are master's and PhD level therapists who are offering goal-driven episodic care. Right. So, ranging from, 4 to 12 sessions on average, highly goal directed, and designed to have an endpoint that's agreed upon at the beginning of treatment. Again, what we're trying to do is drive a new understanding of behavioral health for patients, that you can come in, do a piece of work with a therapist, leave, try it out in the world, and when things get rough again, you can come back either for a booster or for a new episode of care. But basically building this confidence in the model, not just in any given individual.
Wow, that's great. So let me just clarify things for the group or summarize them again. So the BH partner, who you call the linchpin, that master's level social worker who helps both deal with, they're full-time employees. They're sitting in the practice, they're ready for real-time needs within the clinic, and then they also help with the navigation, you call the cubing, and getting that individual to the right points of care moving forward. Then you've got...
Sorry, let me just add, one of the reasons that they're licensed is because we wanted people who had a lot of training in a robust biopsychosocial evaluation of the patient's problems. right? The goal is to get a really full picture of all of the different treatment components that need to be brought online at that point of triage.
And then the prescribing consultants, either the MP or psychiatrist, are they contracted, or are they also with the team? And I understand, you know, they're engaging.
Everyone in our department is salaried employees.
And so you're engaging them through e-consults or a traditional phone hallway kind of curbside. And then if necessary, they actually move over and are seen by that prescriber.
Temporarily.
Got it. And then you've got the therapists that you refer to as BH providers, who are master's levels and doctorate level therapists, who have obviously an end goal in mind, with different probably leading indicators leading to that ultimate KPI when they would sort of matriculate out of that therapy program.
Yep, that's right. And then layered on, in addition, we have some of the specialty clinics that we've developed, right? Our substance use disorders clinic, our bariatric clinic, and our DBT center.
Phenomenal. I just every time I hear about it, I feel like I'm watching like my favorite episode of Seinfeld again. I just love this. All right. So questions are just flying in, which I love. So let me take them in the order that I think they make the most sense for this conversation. So Tad, you mentioned that when you came in, you recognized this disconnect between primary care and mental health and how they were separated out, with mental health being a specialty. Was there something specifically, Carol asked, is there something specifically that you experienced within your patient population that contributed to that decision? Or was it just an overall mindset you had coming into the organization as the CMO?
So it's a great question. So we had historically been very focused on understanding better the drivers of total cost of care within our population, given that we're a value-based care organization, right? So when we looked at our highest expense cohort of patients, we would do what we called roster review. These high risk, high utilizing patients in rosters, and primary care docs would sit down with their teams, sometimes with a case manager, and they'd discuss these patients. And what we found almost universally was that there was a driving behavioral health or substance use disorder associated diagnosis. And we did not have the internal capability at that point to manage it. So we were, leveraging to the best of our ability the existing mental health resources in the community, which, as Sam already alluded to, are insufficient to meet the need. And so what we would have in these roster reviews, which were very well intended, right? We're trying to come up with a collaborative care plan. We're trying to help provide better care for these patients and bend the cost curve. And what we found was we didn't have the expertise to do it. We didn't have the right services to do it. And so we're talking about this person being readmitted and going back to the ER, and we're trying to tweak medicines, and we're trying to get engagement, and yet we're falling short of actually making a meaningful impact on the health outcome and the financial risk that we share in managing that patient's medical care. So that was one of the real clear reasons why we moved more forcefully with, you can hear it's a significant investment. We're talking about a large workforce that is salaried, that is not held to a productivity standard. We need those folks to help engage better care in that population so that we can lower the total cost of care.
And so I'll throw it to Sam. And we got a couple ping pong questions coming in from the audience. Sam, so Tad just alluded to compensation. So I want to go there because a few people have asked about it. How are you defining and compensating practitioners' roles differently? I know everyone's salaried, but how is that being done?
So everyone's salaried. And, our goal is ultimately to incentivize the kind of sort of value-based high quality care and cost reduction that we're gunning for in everybody's compensation. We're not there yet, right? We're still, earlier, relatively early days in the model. So right now everyone's salaried. And then we have, a cost benefit analysis that we review at the leadership level that then trickles down to things like encounters expectations. But the stuff that we really look to, the KPIs that we really follow, for example, for our partners, are things like the number of emergency department diversions they have facilitated in a month. right? Or the number of patients that they have done, 20, 30, 40 minutes of behind the scenes collaborative work to build a care plan, get them connected with the resources that they need, right? So every role has KPIs, but we haven't yet translated those into compensation. It is absolutely something that Thad and I have been discussing since before I even took this job. So it's something that's very much on our radar.
So going back to then, how do you hire, attract, and get PCPs to buy into this? Because that's what Robert is asking. What's the best way to get PCPs?
Yeah, that's great. So anybody who's been in full-time primary care practice where there are insufficient mental health and behavioral health resources understands the frustration of trying to care for people where you don't have the resources to do it. Either you don't have the expertise personally, and I'm a primary care provider, I'm still practicing. So I'll get a patient, a couple of years back, I'd get a patient who's discharged from an inpatient behavioral health unit, coming out on a bunch of medicines that I don't really know about, but they're coming to follow up with me after being discharged. They have a follow-up with a psychiatrist, 6 months down the road, and they're asking me to refill medications. Like, I'm left holding the bag, so to speak, as the primary care doc without a whole lot of good training in that area, and with nobody standing at my shoulder to say, hey, here are the things that you need to pay attention to or watch out for. So with embedded mental health services, I've got access to prescribing, I've got access to therapy, I've got access to someone who can connect to community services like inpatient detox that we don't have right at my fingertips. The value proposition for that, for primary care, is immense. And folks who practiced in that model will not go back to an unintegrated model. Either that, or what they say is, you know what, I can't help you. And I don't know a good primary care doc who says, well, that's a mental health problem, and I'm not going to take care of those issues, because you see the ramifications all through the management of their diabetes, their hypertension, their obesity, their COPD. They're anxious to beat the band. Everything is, manifesting as physical complaints. You're trying to manage that, but you're swinging and missing because you're not actually getting to root cause. So the value proposition is you give PCPs something of value, expertise, access, consultative, real-time, collaborative decision-making. That's gold in this day and age. So that's been our experience. And Sam, I think you can attest to all the comments that you got early on from our primary care leadership saying this is of huge value to us as primary care docs.
So, and I just want to make sure everyone, structurally, BH is a part of primary care. Couple of questions from the audience I'm going to integrate in. How long has the model been in place? And have you been able to realize a reduction in total cost of those patients?
Yeah, so the model's been in place for, it's been fully staffed for less than a year, but we've been running pilots for about 3 years now. And in answer to the question of, are we seeing that value proposition actually sort of in the data? And the answer is yes. So we're on track to do more than 2,000 emergency department diversions this year. And you can use your local math for what an emergency department visit costs and the likelihood that it will translate into a hospital visit. But that's an extremely valuable service. And the only way that can be provided is by making this bet, right? And the bet is that if you leave time open, as we have for our behavioral health partners, and you create this team-based environment, this partnership, and you set this as one of the objectives, that you make this bet that people will actually jump in and help. And what we see is that, for example, nurse triage uses our partners every day with patients that they would otherwise say, it sounds like you're suicidal. I think you need to get to the hospital. But instead they say, I'm going to transfer you to our behavioral health partner. And the behavioral health partner says, great, let's get you in today, because they've got unstructured time and we haven't forced them to fill their schedule with encounters, with visits. And so, short answer is yes, we are seeing the returns that we expected, and we're not even trying to model that remarkably challenging downstream cost offset, right? We're just modeling things that are easier to capture, like diverted emergency department visits, like outpatient visits in the community that instead we handle internally, that would cost us money, right? And these things are already demonstrating enough value that the model is doing very well.
So from an ED diversion ratio, your numerator and your denominator are, when you're thinking about ED diversion, it's number of diversions and what's the denominator on that? Or are you doing it at a point in time?
No, so we do it annually.
Okay.
Right. So
For
this
year to date.
Year over year. Okay.
Yeah.
All right. I'm going to ask, so I want to get into how it works and I want to hear a case study or illustration. But before we do that, I want to knock off some particular specific role questions. So Sam, how many staff do you have? And then Sherry says, I have LCSWs embedded in our primary cares who provide therapy, but we're required to bill. Am I limited to how many FTEs I can have? Therefore, they are booked out for 3 months to see patients. So how many staff do you have? And could you kind of address Sherry's dilemma?
Yeah, let me take the second one first. So,
Okay.
I mean, we already know from really good epidemiology that there aren't enough licensed providers in America to handle the behavioral health burden, period, and end of sentence, right? And so, wait lists become a problem when we follow a traditional model of care, which is, one-on-one therapy. Let me get you in for therapy, right? And here are your choices. You want medication, therapy, or both, right? We need to do better than that in our models of care. So what we do is we do a lot of deploying of things that are much more scalable. Things like apps, things like groups, things like one-way didactics, to help educate our patients about how to do better, taking care of themselves and taking care of those that they love. Because we will never, ever meet the demand by just providing traditional psychotherapy. And so if, for example, you had enough exposure to value-based contracts, you could basically switch those LCSWs over to having 6 hours a day free to support in real time primary care demands. And you could make a bet that by supporting those real-time demands, you're going to offer a better value proposition to your PCPs, and you're going to be able to, for example, reduce emergency department visits sufficient to cover the costs. All right, so that's the bet that we made with the partners. So altogether, just to answer the second part of your question, we've got just under 80 licensed FTE within the department, roughly 15 behavioral health partners on the adult side, roughly 10 on the pediatric side, roughly 20 behavioral health providers who are doing therapy, roughly, if you include adult and PD, a dozen prescribers, and then 8 in our DBT center and another 7 in our substance use disorders treatment team, and then a couple in our bariatric program. Yeah, so that's a very quick rundown.
Could you also explain the benefit of the nurse practitioner in the role you've put them in, because they cost more than a social worker and have this attendee says significantly less psychiatric medication training than PCPs. So can you address that?
So remember that and maybe I didn't make this clear, and forgive me. We employ psychiatric nurse practitioners who are required to have their own residency and training in much more specific psychiatric needs, and they're supervised by our psychiatrists, and we work to skill them up really, really quickly. But they actually come to us with more training than our PCPs have right off the bat. And those PCPs who get to work with them adore them. And so, I would say, they're different from just an NP who, you're right, they get less training than PCPs on psychiatric issues.
And Tad, how does the medical record work to make all of this flow?
So we have a shared medical record. There were significant challenges around the time that Sam came in trying to develop the right protections around what would have been, I think, historically considered to be information that needs another level of confidentiality. But we share treatment plans, right? So you won't necessarily get all of the details behind, say, a complex trauma case or a complex substance use disorder case, but you'll know exactly what the diagnoses are, what the medication treatments are, and it's a shared medical record in real time. These notes are considered, quote, sensitive, and you have to have a certain level of clearance. So, nurse practitioners and physicians can see those, medical assistants and secretaries can't see those. So there's some protections within the EHR to ensure that there's good confidentiality, but we absolutely do not want to create a barrier to appropriate management. And when we have patients who come into the behavioral health, shared, treatment with primary care, we're very transparent about how information is shared, and to the point of actually signing consents around that shared information. So I think patients understand the value proposition that if shared at the appropriate level, understanding what the treatment plan is on both the primary care side and the BH side is of huge value to them. So I think it's been a huge improvement for us in our medical record to have that level of transparency.
So let's put it into a story, a real life story. How does full spectrum care, and I'm using quotes because I know it's an official term, but I like it. You guys should trademark it. How does that model now actually work? Let's provide an example. I don't know who wants to start, Sam.
Sure. So I think the case we were going to talk about was a case that I was involved with a little more than a year ago at our Leominster site. The chief at that Leominster site, who is 40 years of practice experience, had a patient that he was struggling with and had been for a couple of years. The patient was a late 40s Caucasian man who had suffered a motor vehicle accident several years prior, and since then had been a consistent abuser of alcohol, and used alcohol to really manage his pain. He had also been a manager of a grocery store and had lost that job secondary to his motor vehicle accident. So he also used alcohol to manage his emotional pain and his sense of shame and embarrassment after having lost his position. What this guy needed was he needed surgery because he had a number of complications, including type 2 diabetes and worsening obesity that really required him to move more freely and without pain. But he couldn't stay sober long enough for the surgeon to approve his surgery. And this cycle had been ongoing for several years. And so a care team was pulled together for this gentleman that included the behavioral health partner at the site. It included me as the behavioral health provider. It included the PCP. It included an NP or a PA who worked with the PCP. And then we pulled in the substance use disorders treatment team to consult. Excuse me. So that team had, a 30-minute team meeting to brainstorm from multiple perspectives what needed to happen ultimately for this patient to get into care. And care, I mean here, surgery was the target. And then we were able to work within Reliant and the substance use disorders treatment team, as well as with a partner in the community, to establish a 6-month detox and residential plan to maintain the patient for 6 months so that the surgeon could approve and then execute the surgery. And then the team, especially the partner, stayed on top of the patient every step along the way. Very consistent now with what the collaborative care model looks like, monitoring their progress. Then we took a handoff as the patient transitioned out of their residential care, and maintained the patient's sobriety until they were able to get surgery and after that point. So it's a good example of the way in which if you were to sort of just refer the patient out, or if you didn't have enough expertise to sort of bring together a team to plan a full, sort of treatment protocol for this patient, you'd really be, as the PCP had been until we were able to do this, you'd just be treading water, and the patient's steadily declining.
Great. Anything to add there to that, or it seems like we hit everything there?
Yeah, I mean, it's beautiful care, right? I mean, that's whole person care. That's taking advantage of the expertise within a multidisciplinary, medical group that's all, organized around the same, value proposition for patients. And that there's been this continued development of that relationship between the patient and the PCP team, and knows that, gosh, we all know that alcohol use disorder will have recidivism, right? There are going to be ebbs and flows in this guy's life. And having gotten through that challenge, my bet is that the relationship is stronger than ever, and his confidence in our ability to be there to catch him if there's ever a challenge in the future is really high.
And Thad's alluding to something really important, which is that one of the advantages we have by working directly alongside PCPs is we get to leverage their often lifelong relationship with patients to get buy-in and acceptance where otherwise we might be easily dismissed. And it's much easier to say goodbye to a therapist and not show up for your appointments than it is to ditch your PCP. And when the PCP is then saying, hey, Sam told me you no-showed him last week, it makes the treatment much stickier for those patients who may have a really hard time committing or may be very reluctant about engaging.
Yeah, the accretive value is there. I have a bunch of questions I want to get to from the audience and a couple of my own. I'm just going to take a quick pause for two very quick announcements. So folks, next week, if you want to attend another live recording, we have a really special session on the 15th of October. Sherry will put a link up. What autumn means for COVID-19. It's going to feature a panel of physicians, many of whom you might have met already when we did our first COVID event back in March. We featured both an internal medicine doc who was dealing with in New York City during the height of the pandemic, at least at the time, the height, and a cardiologist who was at AICU in New York, also treating COVID patients. We're going to add a couple of experts, including Dr. Michael Sag, who is one of the most prominent infectious disease doctors in the country and has been all over the news since March, speaking to the evolution of this disease. He actually had it himself very early on and just actually posted a really interesting op-ed piece in the Washington Post about President Trump's illness that if you Google, I'm sure you'll see it. So I'm really excited to have that team of doctors on the show on Thursday next week to cover what autumn means for COVID. We're going to discuss the treatments, how they're evolving, how things have changed, and what they're expecting as seasons change and this journey through this pandemic continues. And then the week after that, we have a super exciting panel on what we're calling the super determinant of health, the digital divide. And we'll have a panel talking about some of the challenges there. So go to the website, sharedpurposeconnect.com, click on upcoming events, free to attend the live recordings. If you can't listen to the live recordings, subscribe to the podcast. They'll drop into your phone or tablet as soon as within a day or two of the live recording. To that end, we chose those topics because of your feedback. So in about 2 or 3 minutes, you're going to get an email from me with a survey asking about some of the topics we should cover and how today's episode could have been improved or how you liked it. It's about 3 minutes to complete, really short this week. Please take the time to give us your feedback so we could choose the right programming for 2021, which we're already planning. And that would be a huge favor. I really appreciate it. So thank you in advance for that. All right. I want to talk about, we just covered a really interesting case study. Prior to that, we talked about ED aversion. What about other KPIs you use to measure the success of this program?
Yeah. So we track minutes of collaboration. So
And how do you do that?
through Epic, we actually have what's called a flow sheet where every time a behavioral health partner, for example, does behind the scene work on behalf of a patient, they log those minutes into Epic. Those are then aggregated, and we use those to see, how much time our behavioral health partners are spending on behalf of our patients in a way that has been traditionally non-billable. So that's one metric that we use. Another metric that we use is the flow of patients through our model, right? And this is captured based on the number of triages that we're doing, as well as the number of patients that we're referring out into the community. We typically prefer not to do that. And I don't know about others, but we're certainly experiencing the beginnings of a tidal wave of delayed behavioral health. And so we are seeing more and more pressure on the system for direct care. That's a different topic, but so we also track e-consults. So we'll do about 2,000 e-consults this year, and we hope to increase that number by 50% in 2021, up to 3,000. Those are just automatically tracked through our health record, and are super easy to monitor. We track appointments that we do with our risk patients that, had we not done them, we would have referred them out into the community, and therefore we would have paid for those appointments out into the community. So those are some of the.
How do you define your risk patients? What's that profile look like?
Oh, it's all based on what contract they're in. So it all depends on their insurance provider.
I thought you meant high risk. Got it.
Oh, sorry. No. So we do also do a bunch of patient stratification work, right? So we have a risk pyramid that evaluates their risk of going to the hospital, whether that risk is rising or falling, and that also captures their total medical expense for the past rolling 12 months, for example. And we use lists like that to target, to identify targets of opportunity, and then proactively outreach to those in an attempt to pull them in. And so one of the other things we do is a relatively crude, and we will get better at this as we get more data under the hood and partner with researchers to do some propensity score matching and other good work. But right now what we do is just a crude sort of pre-post analysis of what was your cost, before we got our hands on you, and what's your cost been since we got our hands on you.
You mentioned the community. So I have a question from Lloyd here. What are some of the best approaches to identifying and addressing mental health issues within a community?
Yeah, so this is a little bit out of my scope of practice, because I've focused mostly on helping healthcare organizations, not on helping communities. And so the challenge with a community is, even more so than a healthcare organization, there are a lot of patients who can slip between the cracks and who can go unnoticed, and who aren't using care because they're disincentivized by deductibles and copays, and so they hide under the radar. And I wish I knew more about how we can engage our communities. I mean, we do have a sizable Medicaid population. It was part of the driver for doing this work. But again, they all have a PCP, and we have records on them. It's easier for us to outreach proactively and target and identify those patients. One of the things we are experimenting with is providing, from a licensed clinician, one-way webinars, delivering didactic psychoeducation and support out into the community that's totally scalable, right? You can have 1,000 people watching those. And we're at the beginning, we're sort of at the beginning of that program, but we're basically trying to do that because of this oncoming tidal wave of care problems that we see. But I don't think that we're going to be able to address these needs with traditional psychotherapy and traditional prescribing. We have to be thinking about more scalable interventions.
I'm going to switch to you, Tad. What are your thoughts? This is an audience question from Douglas. Do you have any thoughts on the future of the patient-centered medical coma? Because there's a component, obviously, of BH involved there that feels a little bit like this. Do you have a sense of how your model versus their model is going to evolve, and will they converge?
Sure. So it's a really important question. Really, a lot of what we developed in our care team model at Reliant is based on the sort of foundational structures of patient-centered medical home, right? It's a multidisciplinary team approach to care. In my experience, getting accredited as a level 3, NCQA certified patient-centered medical home gives you absolutely nothing, unfortunately, other than the accreditation, right? You can check a bunch of boxes. It's really actually in doing a little bit more about what you were just asking. How do you match the right care need for the populations that you're caring for within the construct of the medical home? Who needs that full spectrum service within our system, right? So we identified some specific cohorts that we think absolutely need it, but we're also doing, universal screening in primary care to try to identify where we are, currently missing the opportunity to provide that, that full patient-centered medical home experience for patients. So I think it's a brilliant structure. I think it's very intuitive for those of us who've been in practice to know that those teams are going to be more effective, and that different populations are going to need different degrees of sophistication in those teams.
Great. So folks, I'm looking through the Q&A module. I think we've addressed almost every question you've thrown our way, even if it wasn't directly. So if I'm wrong about that, you still have some time to throw some questions in the Q&A module right now, and we'll get that done for you. I want to ask Sam now, what testing are you using to help determine individuals' mental health diagnosis, and how are you measuring the treatment outcomes beyond some of the financial KPIs?
Yeah, so as that alluded, we do screen both in primary care and in behavioral health. We use the GAD-7, PHQ-9, DAS-10, Audit-C, the PCL-5 short form, some of the greatest hits. It is a foot in the door. We can do so much better with regard to screening and testing. We're just not there yet. This is getting people used to having these instruments, but make no mistake, in a couple of years, we'll iterate on that. In terms of measuring outcomes, we in behavioral health collect those same screening measures at every visit. And so we track longitudinally patients' progress through treatment. Again, not the best measures, in my opinion, but it's better than nothing. And we're just getting people used to having their outcomes tracked and taking a look at quality of care.
And Eric, if I might add on to this, and it's maybe, opportunity to come back at a future time. Sam and I have talked a lot about the importance of getting to patient-reported outcomes, right? And to some degree, a PHQ-9 is a type of a patient-reported outcome, but it's probably not sufficient to truly understand the impact to quality of life and the impact we're having in any given treatment intervention. We have developed some internal capability to actually more rigorously assess the effectiveness of interventions. This is what Sam has helped to build internally for us, a practice research network where we can systematically collect data on all patients who come through and watch over time. Based on those types of patient-reported outcomes, we can watch over time to see that intervention A is actually much more likely than intervention B or C to drive important, quality outcomes. So we're not altogether there yet, but I think what Sam's alluding to is the direction that we need to be moving in. That's well above and beyond just the operational or financial or even traditional quality measure outcomes in this space. There's just not enough there yet, and so part of the challenge is how do we build it?
Are you getting reimbursed for the testing, guys?
Yes.
Okay. So I've got a question, and then I'm going to piggyback it with a question that Lynn just posted. So how are you, with this sort of whole person, full spectrum approach to care, how are you incorporating sort of the spirit of empathy and compassion into your overall approach as an organization? It's, very much a training and human resource question, but is that become a focus for you? It seems like what you're trying to do, it almost warrants it. So number one, how are you doing that? Two, how effective has it been? And to that point, Lynn asks, from front desk, from an entire employee standpoint, front desk and assistants are critical in supporting that work. Do you provide training for them so that they could best interact with your customers who walk into the door?
So I'll start, and Sam, I'll ask you to finish. So I would give us credit as an organization only at the level of being aware that this is really critical, not necessarily having fully executed a plan to get us there. I put forward in particular how we as a system respond to the needs of our patients with substance use disorder. There is implicit bias. And unfortunately, there is cultural change that needs to happen. Now, I believe that integration with behavioral health has already started to shift the culture, right? To understand that this is a chronic illness, that this is a treatable condition, and that it's actually in part through empathy that we will be more effective in helping patients to achieve their treatment goals. And so some of that is that our substance use disorder treatment specialists bring that inherently, and it rubs off, right? We watch as primary care providers how some of our colleagues are helping to manage patients with substance use disorder. We do need to be more intentional about it. We've gone through some educational sessions with PCPs and with staff, including front office staff, because as you well know, patients who are struggling will often manifest those behaviors in the clinic, and everybody has to be aware how to de-escalate and redirect. Sam, if you want to add any additional commentary there, I'd appreciate it.
I mean, I think you hit the nail on the head, right? We've been trying to get primary care providers to get waivered for Suboxone, for example, and that work is paying off, right? We have whole sites that are saying we're going to become a site where everybody gets waivered. We're gonna jump in on this, and and how we do it is by those daily conversations with BH, taking away some of the fear and stigma, and making it safer to see those patients and to build empathy and to understand them without feeling like, oh my God, this patient's going to ruin my day now because I'm going to be an hour behind, right? That's a value that we really add for primary care, I think. And then just quickly regarding desk staff and assistants, BH, in my department, we have our own folks that are very, very highly trained and superb. Our PSSs who work in primary care vary a bit more highly. They don't get quite as much training, but they're doing more primary care specific work. And again, the purpose is my department is supposed to click into place the moment the organization identifies that there's a behavioral health need that feels outside of their scope of training, their scope of practice. And so our patient support specialists click into place the moment a patient support specialist in primary care feels out of their depth.
And is there, getting into more care management, is there a difference between a case manager and a BH case manager?
Yeah, so we actually have a whole social work department with social work case managers who are doing medical case management and all that work. The reason that all our folks are licensed is because so much of what we're doing is clinical, even when it involves a case management component. And so, yes, we do some case management work, but all of it is in a clinical context and requires a really robust clinical perspective on the patient's diagnoses and the interactions between those.
So coming up to the close here, Tad, let's go a total full circle from the start of the session. Could you repeat for the folks how large the organization is, number of locations, practitioners that the ADBH staff are supporting?
Sure. So Reliant serves about 325 to 350,000 patients in the central Massachusetts area. We have 19 different ambulatory locations. And over 500 physician and nurse practitioners in our group.
Great. Listen, thank you guys. Thank you for all the time you took to prepare with me. Thank you for the hour. Just loved listening to all of this. Thank you to everyone who's listening and tuned in live, who's listening on YouTube, who's listening on the podcast. We appreciate the time and the trust you've given us with an hour of your busy day. Please take that feedback form that we just sent you out and hopefully we'll see you next week, October 15th, when we cover what autumn means for COVID-19. Thanks again, guys. This will mark the end of today's episode. Really appreciate it.
Thanks, Eric.
Thanks very much.
Great job, guys.